And welcome to the sixth instalment of the Bonus and Mind the Bleep Oncology webinar series. My name's Emma. I'm on the Bonus Call Committee and past chair. We're really pleased to have you here today. Our speaker tonight is Dr. Hannah Beckett, who is an ST6 in clinical oncology, working at University Hospital Southampton. She'll be covering the topic of breaking bad news, which is a really essential skill for OSCEs in clinical practice. So I'm going to hand over now to Hannah, and thank you very much.
Great. Well, hi, everyone. Welcome to this evening, and thank you ever so much for having me speak. So as Emma said, I'm a clinical oncology registrar, and I know these are our Mind the Bleep talks, but with bonus, with a sort of oncology theme with them. And having looked at some of the other presentations that have been happening, they've been sort of slightly more concrete medical presentations. This is the more kind of woolly one, I suppose, breaking bad news. So I have tried to keep it as general as possible, light-hearted as possible, because it's quite a heavy subject, but to also give you some personal experiences in with it as well, which I hope will be interesting. I've said to Emma before, I'm really happy for people to interrupt, but I know it's a bit difficult on this platform, and won't run as well for those watching this on YouTube later on. So please do feel free to put something in the chat, and Emma can let me know if you really want to speak halfway through. But otherwise, there'll be plenty of opportunities for questions and comments and experiences and whatever else you want to talk about after. So I will get started. I hope my slides are moving on for you. I've put a couple of objectives at the beginning. So I hope by the end of this, I will help you to understand why the technique around breaking bad news is so important to consider. I know when you're in medical school and a junior doctor, it can feel a bit tedious doing the kind of comm skills stations. But when you actually start working, you'll see how relevant it is, but also to appreciate a few different models that have been developed to help clinicians preparing to break bad news, understand the various contexts that might affect how we break bad news, and then also just at the end to consider yourself in the picture as well. And we'll go into why that's important. So this is the best sort of definition of what I could find for what breaking bad news is. And lots of people, if you read papers and you search on PubMed for any kind of publications around how to break bad news, will quote this at the beginning as well. And I quite like it. It's that any news that drastically and negatively alters the patient's view of the future. And I think that really nicely kind of puts into context that the patient is the key person here, and it's their feelings and their views and their kind of thoughts that are going to be affected. And it also just highlights how any news could, in theory, be bad news. It's completely down to the patient's perception and how that then changes their view of things. So I guess I was sort of thinking to myself, well, what might be bad news in the context of medicine in general? And I think on the kind of far right-hand end of the scale are the more obvious things that you might think of. So news that you're nearing the end of life or a relative is nearing the end of life, a life-limiting diagnosis, bad scan results, and then kind of moving to the other thinner end of the scale on the left, diagnosis of a chronic illness, withdrawal of drugs due to any reason. In other words, saying that you can't have a treatment anymore because it's not working or the funding's gone. But also negative test results. So we might not think of a negative test result as being particularly bad news, but I think if you think about in the context of a GP surgery where a patient might be experiencing some really bad symptoms and looking for the underlying cause of it, and every test keeps coming back as negative, and you still are no closer to knowing the answer, that can also feel like really bad news. So actually, what is one person's bad news is not the same bad news for somebody else, and there's lots and lots of context into whether or not someone might feel that they're being given bad news or not. Having said that, I think it's really reasonable to be able to predict what might be bad news, and I'll talk in a minute about kind of more obvious bad news deliveries and when you might feel like you need to prepare in advance. But I think the last slide is just to highlight, actually, you can sometimes be caught out and be surprised when someone reacts in a certain way. So I guess because I'm an oncologist and this is an oncology themed webinar, what bad news do I deliver on a pretty regular basis? Well, it might not be in these words, but probably the most common bad news that I have to break is that your cancer has grown. Also that your cancer's back. So recurring cancer, relapsing cancer is often down to us to deliver that news. News that I don't have any more treatment options for you. So that might be because a patient has had really significant toxicity or has become really poorly and we just can't safely give them treatment anymore. Or it might be that they're kind of third line, fourth line, fifth line into their treatment and there just isn't anything else that we could give that would offer them any kind of benefit. We can't cure you is a really common thing that we often have to deliver, I think, especially as clinical oncologists, but medical oncologists as well, because patients often come to us with not all of their staging complete, and it might be that they are assuming that they may be able to go down a curative pathway, but actually we've had some extra scans that show that there's a small metastasis somewhere. That means that actually the treatment intent has shifted from a radical treatment to a non-radical treatment. We can't continue your treatment anymore is sort of similar to what we've already talked about. And then, I'm sorry, this is cancer. So delivering a new diagnosis of cancer, you would think maybe isn't in the remit of oncologists, but actually we do occasionally see patients that have either just not had that news delivered to them for some reason, or who have got what looks like a cancer of unknown primary and we're helping to investigate it, and we do end up giving them the final diagnosis. And we sometimes find second cancers when we do things like PET scans as part of our staging, because you can get unexpected findings that whilst investigating something else. So why is it even important to think about how we break bad news, and why are we even having this talk? So I guess in this day and age, we all have a duty to be honest with patients and give them all the information. So there was a time, within the last 30 or 40 years where actually it was sort of the clinician's responsibility to come up with the treatments and maybe hide information from patients. Obviously, that's not what we accept as the kind of standard thing to do now. So we have to break bad news to patients. There is no other way about it. And we naturally might worry about a person's ability to deal with the news and want to sort of feel like we have to protect them by downplaying the bad news. And I think it's really easy to fall into that trap of starting to go in with the intention of telling someone some bad news and actually then sort of backtrack a little bit and try and be more optimistic than you need to be. So I think part of the skills of learning how to break bad news well is to be able to deliver it and to be really clear and not to give someone false hope, while also trying to control your desire to want to protect them and not upset them. Also, bad news will cause cognitive, behavioural and emotional defects to the recipient. So I think that's obvious, really. Any bad news that person is being given, or their family, is going to have a huge emotional impact on them in ways that we might not really be able to predict for everyone. And that kind of consultation is often a really key moment between the doctor and the patient. So if it's something that's right near the beginning, the quality of that communication can actually permanently affect the patient-doctor relationship, either positively if you do it really, really well, and you've got a really good level of empathy and trust, and it may be the thing that actually determines the rest of whole of their treatment pathway, but also negatively if you start off on a really bad foot with the patient as well. But also the quality of the communication then is going to affect how they react and respond and behave. So it then can affect their compliance with treatments and also how they've sort of psychologically adjusted to their diagnosis. So it's really important to get it right at the beginning if you can. It's really challenging in clinic because the person receiving the bad news will expect to receive more information than just a standard clinic appointment where they're being assessed for chemotherapy or coming to have their blood pressure checked. They're going to expect more information from you, more time, and longer appointment times. And so you also have to be able to kind of deal with moving the conversation on and coming to a conclusion and making a plan. And I think we all know that some people may be more natural communicators than others, and that we all have different life experiences as the doctor. So there's sort of two people in this consultation, isn't there? There's the patient and the news that they are being given, and then obviously the doctor, us, on the other side of it. And because you're all here, you're all attending a webinar related to oncology and breaking bad news, it may be that you guys are all in that sort of section of slightly more natural communicators, and that's why you're drawn to something like this. But not everyone is. Lots of people will go into their subject, like oncology, because of its medicine and chances to do trials and things, and actually know in themselves that communication and breaking bad news is something that they just have to work that a little bit harder at, and ask for support from others. And also we all have different life experiences. So somebody who has got a relative with pancreatic cancer who has been sat in that chair, maybe even themselves, is going to have a completely different reaction, response and experience if they then have to deliver that news to somebody else than someone who hasn't had that personal life experience. I also came across this survey by Bale, who I'll mention again in a minute, which suggested that 60% of oncologists break bad news to patients 5 to 20 times a month. And I guess I'd just like everyone just to think for a minute how often that is and what else you do kind of 5 to 20 times a month. That's almost every day, and you've got weekends factored into that as well. And 14% of those delivered bad news more than 20 times per month. So it's an awful lot. It's a huge burden of our job as oncologists, but also as any doctor really. And this is an old survey. I think it was something like 2000 or 2010. But I would say, based on my own personal experience, that probably still rings true today, if not maybe even more. And I guess the other key thing is that communication can be improved through experience, interactions and training. So whether that's attending stuff like this, whether it's engaging in your own e-learning, or whether it's just getting stuck in on the job, whether they're pleasant experiences or not, your communication will improve. So I thought a good place to start would be just to look at some models that I came across for breaking bad news, because I think they're quite a good starting point just for reflection, for discussion, but also on the job for beginning difficult discussions as well. And they're quite good for structuring reflective practice. So I'm not sure whether everyone here is a medical student or junior doctor, but either way, I'm sure you'll have already come across reflective practice and how important it is now in putting into our portfolios and getting onto paper as well. But I think a bad news conversation or a bad news break is a really good reflective practice discussion point to put onto your portfolio, and actually using these sorts of mnemonics and models is quite a good way then to reflect on it as well. And also I think these models might be able to inspire confidence when you're faced with new and challenging consultations. So the further into your training, the more experienced and comfortable you are with breaking bad news, the less you're going to need to refer back to one of these. But I think especially at the beginning, I thought they were quite helpful. So I wasn't ever taught about spikes in medical school, but you guys may have heard of it. It looks like it was sort of came about in 2010. And is a mnemonic for defining a structured plan. And it was designed for oncology interactions, specifically difficult interactions, but it's very much translatable across any bad news conversation. And then I came across another one called Pewter, which is another mnemonic, which also is for defining a framework to communicate bad news. And it was originally developed apparently as a tool for school counsellors. But again, I actually think I prefer it to spikes as a really handy kind of mnemonic. And And I thought I moved this slide around, so I hope it doesn't seem sort of out of sync. But just while I was on the topic of this, before I go into those models in more detail, I thought I would just pop up this link at the bottom, which I can send out or put on the bottom of the YouTube, which is the link for e-learning for healthcare, which I'm sure everyone is familiar with, or if you're not, when you start working, you will be, because we often trust use it for induction. But it's also got a huge range of modules on it across lots of different topics, and there is one on there for breaking bad news. It's in the kind of palliative care section, and I worked through it whilst I was preparing for this, and I just thought this was a really good summary as to why professionals might find it difficult to answer challenging questions and during breaking bad news conversations. So it might be a lack of confidence on how to approach the situation and therefore avoidance of it, facing the emotional challenge of breaking bad news and dealing with its starkness and finality. It might spark difficult emotions by similarities between that scenario and past experiences, as I've already touched on. Sense of treatment failure, not wanting to let the patient down, being unsure of the prognosis and therefore not wanting to give inaccurate information, and I'll touch on that again later. That questions often come out of the blue, so there isn't actually any time to prepare an effective answer. Time pressures, which make effective communication difficult, a sense that the question would be answered better by somebody else, and that's a really significant thing that I've struggled with, certainly coming through my training. Of that kind of imposter syndrome, and also a belief that there's a right answer, which means professionals can be terrified of getting things wrong. So back to these models. So spikes and pewter, that are both mnemonics, as I said. Spikes stands for setting, perception, invitation and information, knowledge, empathy, and then strategy and summary. And so what they're getting at is that you would work through these in kind of in the order that the mnemonic is. So setting means you should find a physical area for the news to be delivered, and that ideally would be a quiet and secluded area. Perception, so that means you should try to determine the patient's understanding of their disease and the consultation they've walked into before proceeding with the consultation itself. And I guess that might be with direct questioning, saying, do you know why you're here today? Or it might just be by observing their behaviour. I stands for invitation and information. So you're trying to determine how much information would be helpful and to what extent they want to know about the bad news. And again, that might be some direct questioning. So saying to them, do you how much information do you want me to give you? Do you want me to go through the whole scan? What would how would you like me to tell you? And I think that is quite difficult, to be honest. Knowledge, which is when they actually deliver the news, and the spikes model suggests that you should probably do that in small segments and speak slowly to allow them time to process, and also to avoid medical jargon. E stands for empathy, so acknowledge the patient's emotions and their reactions. And you might do that by saying to them, I can see that this is really shocking news for you. I can see that you're upset and you're taking a while to process that. Shall we pause for a minute? And the S then is about strategy and summary. So it's going back over what's been discussed with opportunities for repetition, and then discuss the ongoing management plan and treatment options at the end. And then pewter stands for prepare, evaluate, warning, telling, emotional response, and then regrouping preparation. And prepare this time means knowing what information needs to be shared, how best to explain it, and then arranging the setting appropriately as well. So it's both physical preparation, but also, I guess, sort of knowledge preparation yourself. E for evaluate, so assess what the patient already knows or suspects, as well as what kind of emotional state they're in, how they're feeling, whether they're in a good position and ready to receive the news or not. W is warning, so this is kind of your classic firing a warning shot just before you're about to break the bad news. So indicate there's bad news coming and then pause for them to process that. T for telling, so this is kind of the equivalent to knowledge in spikes, which is actually delivering the news in a straightforward manner. And the pewter kind of model suggests that you give small pieces of information again at a time, but also maximum of 3 bits of information at a time before you're pausing. E for emotional response, which again is similar to empathy, so just assessing their response, but also then reacting to it appropriately. And then regrouping preparation involves an interactive conversation, perhaps between a nurse and a patient afterwards, and discusses their hopes for the future. So it's about kind of trying together with the patient to identify and work towards new goals. And we're really into kind of shared decision making at the moment. It's been a really big topic of conversation, particularly in Southampton. We've had a lot of talks on it from our kind of senior registrars and consultants. And I guess that regrouping preparation includes shared decision making. So giving the patient options and your opinion, but then taking on board what is important for them. And so I was reflecting on how good I thought both of those were, and I think actually the way that I would give bad news and deal with this, and the way that I would use those models, I think would be to do a mix of the two. So my mnemonic isn't great, pukish, but I think I would want to mix a couple of them in together. And get rid of a few of them. So I'm going to go through each of these separately and give some more detail about each section in the next few slides. So firstly, prepare. What do we really mean by that? I think my advice would be that knowledge is your best friend, and there will be some of you out there who can kind of wing it and look confident with less background knowledge and be not in a negative way, but just be able to act a little bit more sort of ad hoc. But I think for me, I've worked out that actually knowledge is pre-knowledge is the way that I feel most confident going into consultations and bad news breaks. So I would always go through their previous letters. You might want to discuss some of the imaging if you're giving scan results with radiologists, or make sure that they've been discussed at an MDT and check what's been said there. Do a bit of research. If you're going to be telling someone something on a ward that you just don't know anything about, then have a read around about it. Often computer systems in hospitals will have access to something like Up to Date, and you can go on there and read a bit about it so that you know roughly what they might ask and what treatments might be available, or speak to a friendly oncologist or a palliative care person, nurse, doctor, or your seniors, so that you're kind of armed with what their advice would be before you go and give someone some bad news. And then try and appear confident in what you're explaining. I know that's really difficult and it's easier said than done, but I think being confident in yourself and having that background knowledge in order to be confident is really important, because if you look nervous, then it's not going to instill confidence into the patient or their family. And like I said, I think then you can be able to predict what questions they might ask you as well. Plan the consultation well. So I would always recommend booking a time where you can either hand over your bleep or where you know it's going to be a little bit quieter, if it's down to you as a junior to break bad news in a ward, for example. But we also still have bleeps as registrars. So I lots of times have been midway through conversations and have just had to take the battery out of a bleep. Obviously not if it's a crash bleep or an emergency bleep, but you can often find someone else who can just cover you whilst you just give that time to a significant consultation. Definitely find a quiet space, so that on all wards there are always relative rooms, always quiet rooms that you might be able to go to. And if not, then, and you're having to do it at the bedside, make sure you're pulling the curtains round and just giving them that privacy and that space. And then I would always invite a family member to join as well. So in our oncology clinic appointments, if we know there's going to be a bad news break or this is a new appointment, we always tell people to bring a family member or a friend or someone with them, both as support, because people just don't know how you're going to react, but also there's that classic thing that we're always told, where you tell someone something bad and then somebody just switches off and never hears anything else, in the whole consultation. I can't remember anything else from it other than the fact that they have cancer. So it's really important to get somebody else who's going to be then leaving with them and going home with them to also be there to make notes and to write things down and to just be an extra pair of ears. And then we often also let them know that they might have some important information being discussed. They often already know that in oncology clinics because they've had a scan, they're anticipating what it might show, and they know that they're coming for the result. But if you're on a ward and you're having to arrange a meeting like this, then you can call someone's family and just say, we're going to give them the scan results. Do you want to come in? What kind of time? Bring tissues, water, bring a friend if you like, so another friendly junior doctor or SHO. And then also just position the room appropriately. So I would always take a chair with me to the bedside. But if you're in a relative's room or something, then just have a little conscious think about where you're going to put the patient and where they're going to sit, so that you can be kind of facing them, so that you are somewhere where you can have sort of open body posture, and where you've also just got space so you're not all cramped in. And then, as I've already said, I think just ask for help. So if you don't know, just ask other clinicians for the most up-to-date information. And if I'm worried about something or I don't understand something in clinic, I wouldn't think twice about going to check with my consultant and just talk it through. And then I would always take a second person with me anyway. So just try not to do bad news breaks alone if possible. So there is always a ward nurse or an HCA, someone around that can come with you, because it's just that little bit of support for you as the doctor anyway. But also, if you have to rush off for any reason, or you're really struggling with being able to answer questions and you just need someone to just deflect things for a moment, then it's really, really helpful to have somebody else with you. And if that's someone that is experienced in this, like a specialist nurse from that cancer site, or a palliative care specialist nurse that's coming with you, then that's obviously even better if they've already got experience of sitting in good bad news breaks. So secondly, E, I'm sorry this is so wordy, I hope everyone's following. Evaluate. So I guess at the beginning, when they first come in, I would say introductions are really important. So let them know who you are and who the others are. But also, I would always give them a bit of a context over how you know their history and their results. Because if you're meeting someone for the first time and you're giving them some life-changing information, I think it's only fair to explain who you are in that kind of context. So, for example, I'm Dr. so-and-so's registrar. I've seen all your clinic letters. I'm working with him at the moment and we've been looking at your scan results. I hope it's okay for me to talk through it with you, and then I'll be able to tell you our management plan after that. And I think you'll find often if you've got a specialist nurse with you in an oncology clinic, then they'll often have made contact with the patient in advance to introduce themselves. And that can also be quite helpful then, that there's a kind of familiar voice, at least in the room, that you can then introduce them to. But if you're on the ward and you're having to deliver some new bad news, you can also explain that you're one of the ward doctors, that you're under the care of this particular consultant who will try to see them at some point, but you're working with them, and that you have had a look at their results and you've got the information and you're willing to give it to them. I guess read the room. So there have been lots of times in the past where I've gone to try and give some bad news to someone, either in clinic or on a ward, and there have been loads and loads of family members there, or friends that have just popped down from the village next door, or we're already in hospital visiting them. So I guess always check who's there and who they want to be there. But also I would always suggest that they gave you a bit of space. So I think generally having more than 3 or 4 extra people can be really overwhelming for that patient when they're receiving the bad news, but they might not realise it. They might just say, oh, it's fine, you know, all my 6 grandchildren, you know, whatever I know, I'm happy for them to know as well. But actually, when you deliver the bad news and you really get into it, it can feel a bit overwhelming when you've got lots and lots and lots of people having their own reactions, looking at the patient, looking at you. So I think it's fair enough to say we can all have a discussion afterwards, but maybe it's best if you just have one, or, you know, pick 1 or 2 people with you whilst we're just actually talking through this. And that also leaves you in control as well, because if you've got questions coming from all different angles, then it's really easy for them to kind of escalate into an out of control consultation, and you want to try and keep these as controlled as possible. And then assess their emotional state. So do they need time to calm down first, just with some comments? You know, it's not uncommon for people to arrive at these sorts of consultations already really het up in anticipation of what's happening. So it's fine to read that and then to say, you know, we can appreciate this has been really overwhelming. You must be feeling really apprehensive. This must be really scary. Do you just need a moment to pop out and get some water? Can we get anything else for you? Etc. etc. And I think also, you know, if they come in and they're really not at all expecting bad news and they're really upbeat and joyful, then giving them that bad news then might be a real huge blow and a real sort of change of dynamic. And so I think if someone comes in and they're not expecting their scan to have been bad, or you know, just have no idea, then I would maybe just move on quickly to the warning shot. So, you know, just explaining, actually, I'm really sorry, but we do have some bad news today. And then you might need to actually take a step back and go back through some of these steps afterwards. But I think kind of bringing them down to the level and of the appropriate level of the consultation is also okay to do there as well. It's just reading what their emotional state is at the beginning. So already, having, you know, done all of that and prepared everything, what barriers might you already encounter before you've even got onto the subject of what you're trying to tell them? So I guess for you guys as more junior doctors, a noisy ward setting with no support is sort of the classic heart sink when you have to deliver bad news to someone, particularly if that's sometimes out of hours, and that's never really good idea. But you will get family members desperate for scan results, or who are only there at the weekend and just need to know, you know, that's the only time they can be there. And with lots of interruptions as well, like your bleep going off or an arrest bleep going off or something else happening on the ward. So trying to think back as to what I used to do and what advice I could give you now as someone who's been through all of that and have experienced a bit more. I guess just try and think about controlling what you can. So if you have to break bad news to someone in a ward, bring a chair, put it up next to them, pull the curtains round, offer some empathic comments and acknowledge their frustrations. So you can say, I really appreciate this isn't an ideal situation. You know, it's a shame that we have to do this while we're in hospital, but and I'm sorry I wasn't able to find any of the oncologists to come and see you, but I can tell you the scan results. I just won't be able to give you all the information. Is that okay? And you can always apologise that isn't the ideal setup, but explain that you just felt it was more important they were updated. And then if you do need to leave halfway through, I think just find an appropriate time. So if you can just, you know, finish the topic that you're on and then find a point that seems appropriate for a pause, you can then say, I'm really ever so sorry, I've had a really important call. Is it okay if I step out and answer it? And then I will come back afterwards. And I've never had anyone say no. And I guess just be honest as well. So lots and lots of the kind of breaking bad news studies and things that I was reading, the top thing that people like is honesty. So if you don't know something, it's obvious to say it, but just explain that you're not the expert. You know this isn't got good news, but you will try and find someone who may know the answers as soon as possible. And people will appreciate that. And then also don't be afraid to organise an appropriate meeting time later on or tomorrow. If it is really 8:30 in the evening, you don't know the patient, you've never met them, they've got really bad news on their scan, you've got the patient and the relatives kicking off that they haven't had the result, just don't be afraid to say, actually, this is not an appropriate situation for me to be giving the news. If it can't wait until the morning, obviously that's a different matter. But if it can wait until the morning when you can be more prepared, you'll have more answers and there's more of a team around, then don't be afraid to explain that to the patient, and then to maybe just organise a meeting time the next day, and then follow that up. What about angry relatives or preconceived faults in the system? So I think particularly at the moment, we're getting lots and lots of people coming to us with diagnoses of cancer, having been to the GP loads, or having called their GP lots and lots and lots, and haven't been able to get appointments. And so they're already perhaps coming to you with frustrations in the system, with, a true or false impression that their cancer might have been picked up earlier if X, Y, and Z. And I guess I would say just allow them to vent their frustrations first. It might be that you just have to spend the first 5 or 10 minutes sitting, listening, nodding, giving them the space and the time to tell their story. And you will then end up just getting a bit of a feel for them as well, and a bit about their journey and how they've got to where they are. If you feel that the consultation is getting out of hand, then I often just try to reel it back in and regain control. I think it's okay to just calmly interrupt someone and then explain why you're interrupting, and just to say, actually, I completely appreciate that your frustrations, but we're getting down a little side road here, and is it okay if we just go back to, we can absolutely discuss that again in the future, but shall we just get back to the news today? And so try and just turn the conversation around to moving forwards. And then you can also offer patients or relatives a choice. So if they'd like a bit of time to regroup, if even after they've had a bit of a warning shot, things have just spiraled and escalated with frustrations, it's fine just to say, actually, should we just all just calm down for a minute, take 5 minutes, go out and get a cup of tea, and then meet back again in half an hour. And then often people, I think, in my experience, just want some acknowledgement over what's happened. And then other things that maybe aren't in your control, so language barriers, cultural differences. I would say always try your best to arrange translators, even on the ward. So we always have a phone service that you can use, and the wards will normally have a portable phone that you can take to the bedside. It's not always ideal to use family members to translate. But if you have to, then you can often get a bit of a sense as to whether they are translating or not. And it might mean that you just have a conversation with the relative beforehand, just to say, I'd really appreciate if you tried to say it word for word. And I think if in some cultures still, it may be expected that the family are the people that are informed about bad news, and it's then down to them as to whether or not they inform their relative or their patient. There'll be circumstances where that's entirely appropriate. For example, on elderly care wards where someone maybe has got the severe dementia. But I think otherwise, I would say just try and stick to your own practice. And we know that, in our UK hospitals, that it is our duty to inform the patient and to check with the patient whether they want their family to be informed or want them to be there. And I think you just have to stick to your guns. And if you're being put in a situation that makes you feel uncomfortable, then I would discuss it with someone senior. And then the other thing that I come across quite commonly is that I will have done all of those steps. So doing my preparation, inviting them in, introducing myself, and then some people will just come out with questions immediately, just asking for the results and then appearing to kind of take over and lead the conversation. And I think for most people, that's probably just a combination of nerves, maybe a bit of personality as well. What I try to do is just to acknowledge that, and then just not prolong the first part of the consultation. There have been times when I've tried to say, sort of got on the back foot and sort of said, hang on a minute, let me just introduce myself first. And that can be okay if I think you handle it in the right way. But I think also you just risk annoying people. And particularly sort of further on down the line, when people have had lots of different bad news breaks, sometimes they do just want to come in and know their result. And that might just be the way that they're dealing with it, is to just know straight away, and then you can backtrack afterwards. So I think it's fine just not to prolong it, move on straight onto a warning shot and say, well, actually, I'm really sorry, I'm afraid it isn't good news. And it is possible then to backtrack. So you can then go do it backwards instead and find out afterwards, after you've given it to them, is that what you were expecting, and work backwards. And I think that's also fine. So next in the mnemonic then, invitation and information. I think this is probably the one of the most difficult bits. And I'm not sure that I always do this in every circumstance. So I think it's fine to try to gauge how much information would be helpful for them. But I think that is difficult to ask that and to know where to fit that in. And it can sometimes, I think, confuse people when, they will sort of answer, well, I just want to know what the results are. So I think unless it's offered to you and they specifically say, don't tell me, all the details, I just want to know, has it spread? They might offer that up to you anyway. Or, for example, say, we just want to know how long we've got. But I think it might be helpful in knowing what they might actually hear. So if they've hinted to you that actually they just want to know a prognosis, then actually it might be irrelevant as to what else you say. That might be the only bit that they're sort of going to clutch onto. And then I think invitation and information might be more relevant in a hospital setting or when results have come back unexpectedly. So, for example, do you want to know your scan results today? Might be more relevant because they've not come in specifically to see you if they're already in hospital. And I think your facial expressions can tell them a lot at that point as well. If you ask them that question and look sort of really, really glum, then actually if they then say, no, I don't want to know the scan results yet, you've kind of already hinted to them what the result is. So I guess just be careful and try and be a bit matter of fact. And then W, warning shot. I think for me, this is probably the most impactful part of the consultation. And I think that's probably one you would have been taught at medical school to give a warning shot. But it's really, really, really powerful part of a consultation. Just saying, actually, I'm afraid it's not good news. And people often then know what the result is anyway. And I think pausing afterwards and allowing them to process it first is really important as well. And to some extent, that will depend on what the news is. If it's actually just that, they've got a liver metastasis that we didn't know about and you're planning to treat them radically, and it's something like an anal cancer or a colorectal cancer, where actually you might still be able to treat them radically, but it just means that they've got metastatic cancer and their prognosis is less, or is going to be more difficult, then you may want to then give them the news but move on a little bit more quickly because you're going to be talking about something a bit more hopeful. And then give them the knowledge. So give them the bad news. I think it's fine to try and plan what you would want to say in advance, and just to practice it, especially early on. You might want to start with the headline, or you might want to explain the context first. So if you're just saying, I'm afraid it does show cancer, you might just want to lead with that. But if you want to say something like, well, we were looking to see if your cancer had spread and if there were any other areas before starting the treatment, so that we knew what treatment to offer you, and actually it has confirmed that unfortunately it has spread to a bit in the liver, then it's also fine to give it in the context of the news. And as I said, I think 3 pieces of information at a time sounds like plenty. Use simple language. So you can always add in something medical if they request it later, but times that I've had consultations with medical people or doctors or nurses, I think they still appreciate you just assuming that they're not medical and just telling them, in normal language. And then also try not to shy away from words like cancer. Try and be clear about what it means. So we spend a lot of time saying that we do have treatments, but it's not curable, and trying to actually be clear about whether it's a palliative treatment or it's a curable cancer and a curative treatment, because people often will not understand the difference between that unless you really spell it out. And then, as I've said, I think pauses can be really, really powerful. So it often feels like something that's really, really awkward to do. And you might need to actually consciously make yourself stop talking to do it. But it's really important just to give the patient permission to have an emotional response and then to ask questions. And often that's the time that I've had the most from a patient, is when you just stop talking and listen. I thought I'd put a quick slide in about talking about prognosis, because we're often asked about prognosis, and I think that's really often a feature of a bad news conversation. And people will often say, I know you can't really tell me, and I know that you don't really know, but, and then ask you about prognosis anyway. So people still want to know their prognosis, even if they know that you can't really tell them. I think it's a very, very difficult thing to predict. And I personally would never give a solid number. I think sometimes even estimating in broad strokes can also be a challenge. So it's fine to use phrases like short, long weeks, long months, maybe short years. Most people with this may get this. Some will live much longer, some may have less time. So there's a real scale. And I often try and say phrases like, I am asked this a lot actually, and the honest answer is that it's really difficult to predict, just because it then sort of reminds the patient that this is what you tell everyone and they're not unique. We're not withholding information about them specifically. And I think things that can help in trying to talk about prognosis is knowledge of that illness again. So you might be able to use numbers from trials, but you'll need to then go into detail about explaining it's a median overall survival, that the type of patient in a trial might be completely different. And you really get things like that from trials that are looking at adding in treatments or their effectiveness. So if we use this treatment, we may get an improvement of 2 or 3 months. But I think nowadays we have to be really, really careful with using overall survival from trials, because especially with things like immunotherapy, you either respond to it really or you don't. So it's not really a case of the individual person getting an extra 6 months or whatever. You know, as an individual, you might not respond and not get any benefit from it, or you might respond and get a really long benefit from it. So I think it's even looking at trials is actually really difficult to then interpret in the patient in front of you. I think knowledge of the patient's current condition is really helpful. So if someone is really poorly, if they're in hospital, if their performance status is poor, then you know automatically that actually the chance of them getting onto treatment is less and their prognosis may be less. Their personal rate of decline, so we can often see if a cancer is behaving in a really rapid way. And you may get an inkling for that. For example, if you have a chap with prostate cancer, which is normally a much more indolent cancer, but actually their PSA is going up really dramatically and really quickly, that might help you to say, well, actually, normally in prostate cancer, people have many years, but your cancer seems to be behaving much more rapidly than that. Know a little bit maybe about opportunities for what disease modifying treatments they may have. And then also I think it's important to ask them why they want to know. So it might be that actually they want to know whether to write a will. It might be that they want to know whether to cancel their holiday they've booked in a year's time. And so actually you may be able to give them some really important and helpful information if you think it's unlikely that they're going to make that, but you still can't give them an exact time. I'm going to speed up a bit because I'm aware I'm over talking, but moving on then to empathy and emotional response. So I think obvious things, watching and listening are really important. It allows you to acknowledge their feelings. And I'd say try not to share in their distress. And I'll mention that a little bit later, because that can actually be quite negative to the consultation. I think you have to be professional, and lots of sort of observational studies have shown that actually sharing in their distress and getting upset or welling up can actually be negative to the relationship with them. So saying things like, I appreciate this is a lot of very shocking information. And you might find that actually they're not able to take on any more information that day at that point. And if that's the case and they are just really heightened and upset, it's fine to then defer it to another appointment. Strategy and summary then at the end. So I guess be prepared to summarise lots of times. You might need to keep repeating information as the consultation goes on. You might need to summarise and use different language if the information just doesn't seem to have been absorbed or understood. And it's often a good time later on for nurses, if they're in the room, particularly specialist nurses with a lot of experience, to interject and offer their observations as well, because they might just have picked up on something that, that the patient's not understood, that you haven't picked up on. And then I guess for oncologists particularly, the strategy bit is often the meatiest kind of part of the consultation. It might be that we're having to change treatment strategies, or we're coming up with some potential solutions or treatments and a plan going forward. And so we might then take up a lot of time discussing treatment options. And often, I think that's often perceived as the most important bit of the consultation as well. So it's nice to have a bit of a summary, pause, and then say, right, now you might need to take some notes, and we'll talk about the treatment. And of course, it will depend completely on the bad news that you're breaking. And then I wanted to add another point at the end that I thought was important, and that is handover. So I think you should always let someone know what's happened at the end of breaking bad news to someone. And if you're on the ward, I would let someone know who's responsible for the patient. So the nurse looking after them, the sister in charge of the ward. Don't just write it in the notes and then move on. I think it's really important for them to know the context of what a patient or a relative has just heard and why they might be looking upset and at the bedside, particularly if you've got to rush off. And I think in an outpatient clinic, you always write a detailed letter to the GP to talk about what you've discussed. And then if I haven't got a specialist nurse with me, then I would always email them and let them know as well, because they probably will need some sort of follow-up support. And some people, will not want that, and it's not appropriate for everyone. But I think, the majority of people will appreciate a phone call in the next few days from the specialist nurse, or another visit the next day. And I think the reality is, as a clinician, you're almost never going to have enough time to offer them the support that they need. So those kind of auxiliary people are really, really important. And always try and offer some sort of ongoing support, even if you're unable to offer treatment as a result of the bad news break. So another clinic appointment just to answer any more questions and check in on them, or referral onwards to palliative care. And then I'll just really quickly go through a couple of examples. So this is a 75-year-old man who I saw recently on the elderly care ward. He was admitted jaundiced and confused. He'd had an oropharyngeal cancer, which was localized and had been treated with radical radiotherapy treatment 6 months before. And he had a difficult time of getting off NG feeding, which is not uncommon, having had treatment to your head and neck area. But it had fallen out at home recently, and he therefore had a lot of weight loss because he'd not been able to eat as well. And I think his family thought that a lot of his sort of deterioration was down to that. So I saw him and examined him. He had a palpable mass in his tummy. He was confused, and then reviewed his CT scan, and he had diffuse metastatic liver disease. So this was he hadn't been informed of it. We had been called because we had been looking after him, and there was no one else really around that could go and break that news to him, but we'd been asked to review him. So I think, thinking back on it and reflecting on everything that I did, which I'll go through now, I did most of those steps actually without thinking about it. So I called his wife and arranged a time to meet. I phoned our head and neck specialist nurse to come and join us, as well as the ward doctor, who actually couldn't. So the two of us then regrouped, went through his scans, and went to see him together when his wife had arrived later on. We arranged chairs around the bed. We introduced ourselves, explained the context of things. I was the on-call oncology registrar, but that I worked closely with his consultants. I summarised his symptoms, and then re-summarised why the CT had been booked, and that our concern was that this could be a recurrent cancer. Then gave them the results. We offered them lots of empathy. We explained that actually there was unlikely to be any treatment options for him because of his liver function and general status, and that we'd asked palliative care to come and help with his symptoms. We gave him a bit of hope at the end and his wife, and that we were going to get the images reviewed with HPB to see if there were any interventions, and RMDT. And then gave them time for questions. I definitely missed a couple of bleeps during that, which I think was okay in the context, and then just got back to them later. I offered the specialist nurse to stay with them, handed over to the nurse looking after him and the ward doctor, and then organised follow-up by handing it over to my colleague who was on call the next day to then go and review him with the results of what we discussed with HPB. And that was quite a good outcome, I think. Not for him, but for in terms of it was a good bad news break, and they were appreciative of it. And then the other example, which I think was completely different, was a 38-year-old lady who I saw in Portsmouth actually last year, who was originally from Ghana. She'd been admitted under oncology with a known cancer, but she had gastric outflow obstruction and jaundice. She had a background of colorectal cancer. She'd recently had some really radical treatment to some brain metastases, which would therefore you'd assume that her prognosis at that point had been quite good. And I saw her CT result on a Sunday afternoon on an on-call, and it also showed widespread liver metastases causing her jaundice. So this time I called the on-call interventional radiology and gastro team, who said that they didn't think there was an option for drainage. They were unlikely to be able to decompress it. So in other words, we were probably not going to be able to get her onto any chemotherapy. I went to see her. She was quite well. I asked if she wanted to know the scan results that evening, and she did. I asked if she wanted to call her mum in, who she lived with, but she declined and didn't think that she'd want to come in at that point, and that she'd rather find out the news without her. So I asked one of the nurses on the ward to join us in the quiet room on the ward, and then had quite a lot of pushback actually from some of the nurses about whether I should be telling her at the weekend. But I think it's your responsibility with the patient to make that decision. I gave her some appropriate warning shots, explained why we'd done the scan, what we were worried about, and then explained the results, and that unfortunately we were probably not going to be able to give her any more chemotherapy. She was cleanly devastated, and she did find it difficult to display emotions because of the brain metastases. And it wasn't ideal because we didn't have any specialist nursing support or relatives. But I think actually she was really grateful for being told the news, because sometimes waiting around is harder. And she was appreciative of the fact that actually we'd need to get a bit more information the next day before we could get her seen by her own consultant. I thought I'd mention really quickly about different attachment types of patients, but I think it's probably outside of the remit of this talk. But there is a lot of research into how different kind of personalities and attachment types of patients can influence consultations. I think the bottom point I've made is the important one. So as an oncologist particularly, you're likely to break bad news multiple times to the same patient. As their disease stops responding, you move on to the next line, you get bad news again, etc., etc. And so actually that will allow you time to build up a rapport with the patient, and that is the ideal situation, is that you can then adapt to them, knowing previously how they've responded and how they like to be given news. I wanted to do a quick mindfulness exercise at that point, but I think we've probably run out of time. But I think some good techniques just for in clinic, if you then are giving a bad news break and acknowledging that actually you're finding it difficult yourself. So a really good one is just a 4-7-8 technique. So that's breathing in for 4 through your nose, holding your breath for 7 seconds, and then breathing out for 8 seconds. And you can do that during a pause, just to sort of take a bit of time and get a control over your own emotions if you're finding it difficult. You can also use the time when you may examine the patient, go and wash your hands, just to look at the wall, look at a mirror, and then breathe in a rectangular manner. So breathe in across the long rectangular side, out across the short rectangle, in across the long rectangular side, and just focus on that. And there are lots of other mindfulness exercises, but things you can also do in a clinic room, for example, or if you just step out of the room for a minute, is 5 senses exercise. And I think, preparing yourself for these as well, make sure that you're well fed and you've had a drink, make sure you've had a break before. I've already talked about preparing and positioning the room, ask for other people's help, and then try and use those mindfulness techniques if you do feel you're struggling. And I'm really interested in compassion fatigue and self-awareness, but I think it's just really important just to raise it at the end of a talk like this. In that actually, I really like that quote that we only have a finite reserve of empathy, and like a candle, we can run low and burn out. I think, you need to learn how to find just the right amount of empathy. Try not to overshare your emotions with a patient. As I said, personal distress can sometimes be negative. And also developing compassion fatigue can result in avoidance of similar experiences in the future. So if you find something like this really, really tough, then it's okay to take some time. Try and reflect, as I've said, either with friends, colleagues, or even better, writing it down in your portfolio. And that might help you to process why you were affected that way, how you could manage it in the future, particularly if something went wrong, which will happen lots and lots of times. Or if you just something hit you and you just found it really difficult. And there are lots of groups now around in hospitals that will help with that, like Balance groups or Schwartz rounds. So I think in summary, breaking bad news will be a factor in all our jobs. There are models you can use to help give you a bit of confidence in what you're doing. We can probably acknowledge what challenges might pop up in advance and make a plan on how to deal with them, but not always. And then really, really importantly, just consider your own mental health and how you're going to deal with having to deliver bad news during your career. And that's all. Thank you very much.
Thank you very much, Dr. Beckett. That's a really brilliant overview. I think it's a really difficult topic that we don't necessarily get much teaching on either at university or as a foundation doctor and beyond. So I've definitely learned a great deal, and I'm sure lots of other people have as well. If anyone has any questions or comments at all, please post them in the chat. There is one, I don't know if you can see it, essentially.
Shall I stop sharing, Emma?
You're okay. I can read it out if that's easier. So the question is, if someone does not want to know the result, what do you do? Do you just not tell them? And are there any times when not telling them will create other problems?
That's a really, really good question. And I did have another example in mind of something similar that I was going to mention and forgot, actually. So thanks for reminding me. I guess recently I had a lady in her 40s who had been diagnosed with cervical cancer and came to clinic with her husband. And she specifically said she didn't want to be told anything about it. She just wanted her husband to know. She was happy to sign the forms, but she just wanted to get on with treatment. And she was a really anxious person, I would say, but also she had a really young daughter who was only 4 or 5. And I think, the thought of having, an advanced cancer was just too much for her to have processed, because these sorts of diagnoses happen really quickly, and you're seen in clinic really quickly. So there's often not much time between them having the initial news and then seeing you. But she needed to be consented for radical treatment, which involved radiotherapy, chemotherapy, brachytherapy, which is a really invasive form of radiotherapy. And so we've got to talk through all of that with them, and we've got to explain why we're doing it and consent them properly. So in that kind of circumstance, I guess that could cause problems if they didn't want to know, because it's down to us to get informed consent. And not having that just would mean that we wouldn't be able to do the treatment. So I had to spend quite a lot of time with her and with our specialist nurses exploring that a little bit more, and then trying to give her enough information, but not lots and lots of information in the way that some people might want to. But I think in terms of other circumstances, if there's a patient on the ward who's really, really poorly and just doesn't want to know the results of a scan, it is always their prerogative not to know, and that's okay. And I think if a relative wants to know, then, and particularly if there isn't anything you're going to be able to do for them other than keeping them comfortable, then people might not want to know all the details or what exactly is wrong with them. But I think if a relative wants to know, then you have to make sure with the patient that they're happy for you to share that information. I hope that answers the question, sort of.
That's great, thank you. If you haven't done so already, please could you fill out the feedback form, which the link for is in the chat. Just quickly, our next session will be on the 4th of July on hemato-oncology malignancies. And I'll post a link in the chat. We do have a couple more questions, but I am cautious of time. Are you happy to take a few more, or we can?
Absolutely, yeah, absolutely. If everyone else is okay to.
So one of them is, how would you manage if a crash call essentially occurs whilst you're having, or essentially breaking bad news? How would you manage that?
I think the ideal thing would be that if you're on call that day, you're not necessarily the person that has to do the bad news break. But also, I think if you do, then I think that's one of the reasons why it would be important to take someone with you. So if you can then leave a specialist nurse or a ward nurse with the patient while you just run off and run back, at least they're left with someone who will have some medical knowledge and will have been there to hear what was being said. So I guess that's one reason why that's always a good idea as well. But otherwise, you have to go to that arrest call. So I think most people would hear that emergency bleep going off, and you would just have to say, I'm so sorry, I will come back. This is an emergency. But also definitely just tell the patient and their relative before you start the talk with them as well, and just explain at the beginning, I just to let you know, I am on call today and I've got an emergency bleep, so if it goes off I will have to run off. I hope that's okay and you understand. That's probably what I would do.
Perfect, thank you. And just one final question, if we can. Do you have any suggestions for counselling patients who may become upset or angry after you've delivered the news?
I think there's probably some general things that you could do, but I think in a way it would be maybe unusual or rare to get people who react completely unexpectedly. I think that's maybe why a lot of the kind of lead up to actually giving the information is important, because the time that you're kind of buying by, flicking around the subject, it might seem at the beginning, introducing yourself, talking about what they already know, is partly for you to get a general feel for what kind of person they are and how they are reacting to you speaking anyway. So I think probably you can try and avoid those unexpected extreme reactions by the kind of preparation beforehand. But absolutely there will be circumstances where you are faced with that all of a sudden. And I think a sort of anger is just often a person's way of not being able to control the extreme kind of anguish that they're feeling. So probably just standing back, giving them a bit of space and time, agreeing with them, and looking to your colleague who's in the room, hopefully with you as well, and just kind of taking their lead. I think if it gets into a kind of really confrontational situation, that's obviously different, and you can definitely just step away for a while and say, I'm just going to leave, and give you a bit of space. But I think there have been lots of times where people have burst into tears, have been uncontrollable. I've also had, I think lots of my colleagues will have had the same experience of the patient who is fine, seems okay, but seems really upset, and then comes over all white and suddenly is sick or faints, and you have to get them onto the couch, and they just have an extreme kind of anxiety or autonomic reaction, and that's just you just have to be understanding, I think, and give them the time afterwards, and just accept that you're going to overrun your clinic, and it might be that actually your specialist nurse or a nursing clinic takes them off for a while into a different room, and then just talks through and explores a lot of their feelings and emotions. Or as a junior doctor, you might be tasked with doing that as well, while you just move on with something else and then come back to it later. And there have been lots of times when actually you've said they're just not in a good enough emotional state to process treatment discussions and things now, or consent for anything. So you just book them in again for a week's time. And that's okay to do as well.
Brilliant. Thank you so much. I think that probably closes our session quite nicely. Thank you everyone for all of your questions and for attending, and thank you again, Dr. Beckett, for your brilliant webinar. As I say, the next session will be in a few weeks' time, and I've posted a link for registration. But thank you all very much, and hope you enjoy the rest of your evenings. Thank you.
Bye.
Bye-bye.